Thank you for joining me today. My name is William Reisacker, and we're going to be talking about the ENT Manifestations of Allergy. Now, no matter what type of ENT practice you have, whether or not you're practicing facial plastics, otology, head and neck, or particularly if you're practicing a heavy rhinology practice, you're going to see a lot of patients who have allergic disease. This is a very common problem affecting maybe a third of the patients, even up to a half of the patients who are coming into our office. So I would encourage all of you to think about allergies at least once during your evaluation of each patient. Now, of the 80 million people who have chronic rhinitis in the United States, this can be divided up into allergic rhinitis and non-allergic rhinitis, and there's also a group who has overlap in these conditions, and that's called mixed rhinitis. So we can divide up chronic rhinitis into allergic rhinitis and non-allergic rhinitis. Non-allergic rhinitis is a large category. It's sort of a catch-all category for many different conditions, including irritant rhinitis, people with air quality issues, drug-induced, hormonal, atrophic rhinitis in elderly patients, occupational rhinitis, vasomotor rhinitis, chemical sensitivity, and then those rhinitis conditions that we really don't know what's causing them. Then on the other side, we have allergic rhinitis, and that we can divide up in a couple of different ways. Those who have systemic evidence of atopy, those are our seasonal, perennial rhinitis patients. And then there's also those patients who don't have systemic evidence of atopy, and those are what we call the local allergic rhinitis patients. But they can present very similar to those patients who have allergic disease with systemic evidence of atopy, meaning IgE present in the serum or positive skin prick testing. Now, in this slide, this is a very important definition between atopy and allergy because many people use these conditions and these terms synonymously, but they're actually very different. Atopy reflects the genetic predisposition to form IgE when you're exposed to different things, such as foods, inhalants, or if something contacts the skin. This was actually first described in the dermatitis literature, and it means a different location or absence of location because you could have an exposure in one area of your body, and then you can have a reaction in a different area of the body. Now, allergy is the clinical manifestation of atopy. So in order to determine this, you actually have to see the person in the clinic, and they actually have to be having a medical problem. This is type 1 hypersensitivity that we're talking about. And the conditions that this is associated with include things like atopic dermatitis, eczema, although not all eczema is atopic related. Also asthma, and same, not all of that is related to atopy. Allergic conjunctivitis and allergic rhinitis, which by definition are allergic in nature. And then also eosinophilic esophagitis, which is very heavily associated with atopic conditions, but increasingly likely that there are non-IgE mediated reactions that are going on causing this clinical syndrome. And these conditions can, of course, lead to other ENT-related problems. Now, there's a huge socioeconomic price tag associated with allergic rhinitis, both in children as well as in adults. With children, it's about missing school, not performing well in school, and that can be either due to the disease process itself or even due to the medications. For adults as well, missing work, not performing as well as they should. The costs for allergic rhinitis are actually higher than asthma, cancer, diabetes, or migraine headache. We can see here that in the work productivity activity impairment questionnaire, we see an effect on classroom productivity for kids, work productivity, and not only the ability to do their daily activities, but also the ability to socialize, to maintain relationships. So this affects people throughout their entire lives and in many aspects of their life. Now, the majority of all people in the U.S. and worldwide will test positive to one or more antigens. Now, many of those people are not symptomatic, But if they are, the most common sensitivities are dust mite, and then pollens like grass, ragweed, and then also cockroach as well in other animals. The incidence is actually very low in infancy, and then it rises as you get into young adulthood, and the peak incidence is in later adolescence. And then we see a declining incidence as we get towards adulthood. So if you see a person in your clinic in the 60s or in their 70s that are complaining of new onset allergies, that should be a red flag to you that perhaps there's something else going on. Maybe there's an air quality issue in their apartment, or maybe even cardiac disease is going on, which can give them lung symptoms. So always a red flag when older people come in complaining of new onset allergies. So what are the risk factors for allergic rhinitis? Well, certainly there is a genetic component to this. If you have no parents or siblings who have atopic or allergic disease, then the risk is much lower. Whereas when parents have allergic disease as well as siblings, that risk rises. However, there's also environmental influences on allergic disease. There's an increasing prevalence of allergic disease that we've been seeing over the past 5 to 10 years. However, it seems that the incidence of allergy in the farming community has remained relatively stable. We see in the Amish community, for example, that the incidence of allergy is about 10%, and that's what we estimate the natural prevalence of allergy should be. And the reasons have been discussed. There's been discussion about the hygiene hypothesis, and the exposure to bacteria and other elements such as raw milk may actually help drive your immune system and your T helper population towards that Th1 or the pro-bacteria and virus fighting phenotype, and away from the Th2 or the allergic phenotype. So when should we think about allergies? As you can see, these are many conditions that we see every day in our clinic, particularly chronic rhinosinusitis with polyps and ear disease, and many of these can be manifestations of allergy. We see many people with the many syndrome, which is many different complaints, and many different treatments, many different doctors, many different failures, and we all have many of these patients. So again, I would recommend to all of you that you think about allergies at least once during your encounter with the patient, particularly if they're having some of these complaints or these problems and they've been managed over and over again and they're not seeing any relief from the treatments that have been given. Now, the diagnosis of allergy, like many things, begins with a good history and a good physical exam. Much of allergy can actually be diagnosed just using the history and the physical exam. With a history, you want to get all the elements of that history. However, with allergy, you want to really get a good social history. How long has the problem been going on? Is there a seasonal variation to it? Does it get better in certain conditions? Does it get worse in certain conditions? Have they tried any medications? Has anything changed in their environment with either their apartment or their work environment? Has there been any renovations or water leaks? These are all the questions that you need to really delve into to figure out what's going on with this patient. This physical exam, of course, includes the complete head and neck exam, including the skin, the eyes, the lungs. With allergies, you may have to break out a little bit beyond your ENT territory. And listen to the lungs and see what's going on with the patient's skin as well. But that will really help your diagnosis of this condition. Nasal endoscopy, of course, laryngoscopy. This should be done if the complaints warrant those exams as well. And then if you have this available, allergy testing is the next step. If the patient has any prior results, it would be great for them to bring those so you can compare to the results that you get. It's really necessary to make that definitive diagnosis. Just like when people come with hearing loss, we get an audiogram to confirm that diagnosis. And certainly you want to do the same thing with allergy testing as well. And certainly allergy testing is necessary before you would think about initiating immunotherapy. And immunotherapy will be a subject that will be an entire lecture to itself. Now, these are the classic symptoms of allergic rhinitis, although not every patient has this classic constellation of symptoms. Certainly sneezing, itching, runny nose, these are the most common complaints that you're going to see in a patient who actually has allergic disease. But as you can see, there's a lot of overlap between people who have allergic disease, people who have the common cold, people who have chronic sinusitis. So again, it's very important to really take a nice detailed history when you're evaluating these patients. So this is a diagram about what exactly happens when an allergen gets into the system. How does sensitization occur, and how does that lead to further symptoms? So here you can see the epithelium, a mucosal epithelium, and Langerhans cells, also known as dendritic cells, because of all these fingers, dendrites meaning fingers, and these are antigen-presenting cells. And then we see below them, we see the T cells. We see initially naive T cells, as well as naive B cells as well. So the first step towards sensitization involves the allergen gaining access to the mucosa. In this case, it's a pollen granule, which gets picked up by the Langerhans cells. Then the Langerhans cells, which are activated, interact with T cells. At this stage, a naive T cell will decide whether or not it's going to react to that pollen granule in an allergic type fashion, and that T cell will differentiate into a T helper 2 type cell. If not, then it may decide to differentiate into a T helper 1 type cell. Once the T cell has been activated, and if a Th2 pathway has been chosen, the T cell will interact with the B cell, and then the B cell will figure out what it wants to do for the rest of its life, which is to produce antibodies towards that pollen granule that initially came into the system. Now, this can occur in the mucosal tissue. It can occur in the regional lymph nodes. It's important to realize that the mucosal tissue and the epithelium itself has all the machinery that's necessary to provide this isotype or class switching. And this also leads the way towards local sensitization, which we spoke about a little bit before. And once these antibodies are produced, they then travel back to the epithelium, to the mucosa, where they attach to mast cells and to other lymphocytes. And then when the allergen gains access to the system once again, we see that type 1 mediated hypersensitivity reaction occurring. So let's now talk a little bit about the physical exam that we see in patients who have allergic disease. And we'll talk first about the general appearance. Even before you've said a single word to the patient, you can gain a lot of information by just observing their activity level. Oftentimes, children will appear restless and have a sad expression, while on the other hand, adults may appear fatigued, and that could be due to the allergies or to the medications that they're taking to help treat their allergies, or the fact that they're not getting enough sleep because of their allergies. We're going to talk a little bit about some gestures that we tend to see in allergic patients, including the allergic salute, grimacing, and an interesting sound that's made called clucking. So this is the allergic salute. This is a palm, an upright turned palm that's put against the nose and then upward rubbing. And you can see that's a pretty irritating thing to do over and over again to the nose. And it can lead to this, which is a supertip crease. This requires about 2 years of the allergic salute, but actually that line you see in the nose can become permanent. You may need rhinoplasty in the future to help with that. And you can also get dermatitis and acne in those folds of the skin. So this is what's known as grimacing. This is done when older kids realize that it's just not cool anymore to be rubbing their nose with their hand, and they figured out a more clever way to get to that itching that occurs in the back part of the nose. Many times kids can get in trouble for doing this. They'll be sent to the principal's office because the teacher thinks that they're making faces at them, but really they're just trying to get to this itching. And this is not just in young kids, it's older kids and in Olympic athletes as well. To take care of that itching that occurs in the back part of the mouth and in the throat, they also do an interesting sound called clucking, which actually sounds like like clucking. And it's a way of really getting to that deep itch that's behind the tongue and in the throat. So on the physical exam, facial features are very important to look at. There can be dry, scaling skin, and this can be related to eczema as well. It may become erythematous. Remember, eczema is not a rash that itches. It's an itch that rashes. There's chronic irritation below the nostrils because of all the running and the rubbing. Long silky eyelashes are also present. Why that is the case, I'm not sure, but this is a finding that you will see in allergic people. Also, allergic shiners, adenoid facies, Denny-Morgan lines, and a supertip crease. We're going to go over those. Now. So allergic shiners are really related to impaired venous drainage. Normally, the blood circulates through the sphenopalatine system posteriorly. However, if the nose is congested, that blood then has to drain anteriorly through the angular vein and the palpebral vein, and there becomes engorgement of those veins, and then hemosiderin deposits, which unfortunately can become permanent. Denny-Morgan lines, you can see those horizontal lines underneath the eye. This is related also to orbital venous stasis, and oftentimes they go along with the allergic shiners. There's local hypoxia and then spasm of Mueller's muscle, and that's what produces that crease, which also, just like allergic shiners, may become permanent. So this is what we refer to as adenoid facies. This is a very characteristic appearance that you'll see in people on the street and in patients that come into your office. They have a long, narrow face, kind of a dull expression with the mouth being open. The upper lip is retracted so you can see the upper teeth. There's a recessive chin. The cheekbones are less prominent, a wide dorsum, nasal dorsum, and a narrowing of the nares themselves. What we're really looking at here is mid-face hypoplasia, and the reason for this comes from the nasal congestion. When we have venous congestion inside the nose, this leads to tissue hypoxia, which then will lead to acidosis, and in an acidotic environment, the bones don't develop properly. So we see improper development of the maxilla, and we'll also see in a few slides poor development of the palate as well. So the ears can be affected in multiple areas. The external ears can be affected with contact dermatitis or an eczema-like appearance. There's itchiness and scaling of the skin. The middle ear can also be affected. The eustachian tube is one of the shock organs for allergy, as is the ear, nose, and throat region. We see increased edema and vascularity of the middle ear mucosa, and that enhances gas exchange. So you have absorption of nitrogen, of oxygen, and that can create that negative pressure inside the middle ear space. The middle ear mucosa also plays an active role in antigen-specific IgE production. I spoke a few slides ago about the ability of the mucosa in the nose to produce IgE and undergo class switching. Well, that's also seems to be an ability of the middle ear mucosa as well, which makes sense because it's respiratory mucosa. The inner ear can also be affected by allergic disease through a sense of chronic dizziness, a floating sensation. Vestibular or cochlear hydrops can occur, and your patients with Meniere's disease, there's certainly been an association, particularly with food allergy, and it's worthwhile testing those patients when they come along. In the nose, this is the most common appearance. This is what we're most familiar with seeing, and what we most often associate with allergic disease, that pale, boggy mucosa, the pale blue turbinates. On the posterior aspect of the inferior turbinates, you may see what's called mulberry tips, or an irregular type of swelling in the posterior aspect of the inferior turbinate. Just note those as you're going by with endoscopy, and there have been cases in the past, which I've seen, where patients have undergone extensive resections for these lesions, with the clinician suspecting that this is a cancerous type of condition. Clear watery rhinorrhea is a very common symptom, along with sneezing, itching, Polyps may be seen inside the nose, so it's good to look with a nasal endoscope. Hyperplasia in the adenoids are also seen, and edema in the eustachian tube orifice as well. And here we can see on the right-hand side nasal polyp in the middle meatus. Now, the oral cavity, typically the person with allergies is breathing through their mouth. Their mouth is open. They have dry, chapped lips, again, because they're breathing through their mouth. They can have bad breath as well as gingival disease. A geographic tongue is something that can also be seen in allergic disease, along with cryptic tonsils and hyperplasia. Submucosal lymphoid hyperplasia in the posterior pharynx is also very commonly seen. This is called cobblestoning. And if you look in the upper picture, you can see those lymph nodes, those oval, yellowish appearing lymph nodes that are right underneath the surface of the mucosa. You can almost see the blood vessels supplying them as well. This is an excellent picture of that. And then you can also see that high-arched V-shaped palate. And again, this goes back to what we discussed before with hypoxia and acidosis of the tissues. You see a difficulty in the development of the palate, and that can lead to that cathedral palate, that arched palate, that V-shaped palate that is so often associated with nasal obstruction. Now, the eyes, the vast majority of all allergic eye disease is going to be allergic conjunctivitis. Mast cells are very abundant in the conjunctiva. Typically, this is seen in both eyes. So if a person presents with difficulties in one eye, you have to really keep that differential wide open for other types of conditions. But the symptoms they typically have include itching, burning, and tearing. Now, the larynx, some of the common symptoms we see in allergic disease is hoarseness, postnasal drip, common chronic cough, a globus sensation, and we tend to see edema or swelling of all the laryngeal structures. So it's sort of a global edema of the larynx, as opposed to, say, reflux, where you may see more edema and erythema in the posterior postcricoid region. Now, the physical exam in the chest, this would require you to perhaps find a stethoscope, which is not a bad idea if you're seeing allergic patients. Asthma is the most common manifestation, but not all asthma wheezes. Many times kids with asthma can also demonstrate this cough variant. When they do have wheezing, it's usually at the end of the expiration or the exhalation. So the best place to listen is a few inches below the clavicle, just lateral to the sternum, and that's where you can hear those wheezes. So that concludes the ENT Manifestations of Allergy. I'd like to thank you all for listening to me today.